Hello and welcome to Digest This, where we focus on clinical topics in gastroenterology. My name is Francesca Moroni. I'm one of the gastroenterology consultants in the north of Scotland. Today we discuss achalasia, and I'm delighted to introduce Ms Vicky Ritchie, a GI specialized physiologist in Aberdeen Royal Infirmary who is undertaking higher training to advance her clinical role, and she undertakes outpatient clinics. Welcome, Vicky.
Thank you, Fran, and thank you to SSG for giving me this opportunity to talk to you today.
So, probably it's fair to say that achalasia is one of these under-recognized gastrointestinal conditions, and many people, even in GI training, have not heard of it or not been able to confidently diagnose it. What is achalasia and what is the prevalence in the UK population?
So achalasia is a neurodegenerative motility disorder, and it affects the esophagus and LOS specifically. What happens is the inhibitory neurons specifically are targeted, we think, by an inflammatory mechanism, and it causes those nerves to die off. So the effect of that is the esophagus loses its ability to contract in a peristaltic manner, and also the LOS fails to relax, it becomes spastic. The data on the prevalence is quite scarce, but we think it's somewhere between 10 to 15 per 100,000 population. So for the UK population of about 67 million, we would think there would be about 7 to 10,000 patients with achalasia.
How do typically patients present?
Most patients present with dysphagia and regurgitation, usually to solids, but if the disease has progressed, it will be to liquids as well. By the time they present, if it is in the more severe end of the spectrum, then they usually have some weight loss and might have nutritional compromise as well. About a third of patients will also have chest pain, and we don't really understand the chest pain either. It doesn't seem to be particularly linked with food or anything, and it can last between a few minutes to several hours. So in our clinic, we'll utilise the Eckert score to characterise all of that and get an idea of the severity. And that's also a useful tool for looking at patients after they've had a therapy, because a score of 3 or less generally indicates a good outcome.
So how do we diagnose it?
The gold standard investigation for diagnosis is high-resolution esophageal manometry. So that's a test where we pass a nasogastric catheter down through the LOS into the stomach. There are sensors along the length, and that tells us about the contractility and so the function of the esophagus. The cardinal feature of achalasia is that the sphincter fails to relax. In the advent of high-resolution manometry, we're now able to categorize achalasia into 3 subtypes. So all 3 types will have failure of the LOS to relax, and we use a metric called the integrated relaxation pressure to look at that. It measures relaxation over a 4-second period. The cutoff for that will depend on the system a service has, so it's worthwhile clinicians being acquainted with their services kit and the normal ranges for that. We also give sips of water so we can look to see whether the patient has peristalsis. The type 1 achalasia is the type which most people will be common with, where the esophagus dilates and you have that typical bird beak appearance on a barium swallow. The type 2 achalasia is thought to be a precursor to type 1, so the manometric features there will also be that the sphincter doesn't relax, no peristalsis, and we see these bands of pressure, which is basically the water just being held up in the esophagus. Type 3 achalasia is spastic achalasia, and that's a little bit different from the other 2. We don't think, or at least in literature, it's not thought that they are related pathologically. So with that one, you will see some contractility in the esophageal body, but it's not normal. When we measure the distal latency, it's less than 4.5 seconds. That's the hardest one to treat. It's got the lowest prognostic outcomes.
So clearly high-resolution manometry is the gold standard, as you mentioned, where we demonstrated that the lower esophageal sphincter doesn't relax. Is there a role for endoscopy, barium swallow, or rather cross-sectional imaging in diagnosing achalasia?
Yes, generally by the time patients come to the physiology lab, they'll have had organic disease excluded. So they'll already have had an upper GI endoscopy. So when they have their endoscopy, endoscopists might comment that there was difficulty passing the scope through or the esophagus looks dilated. However, it's not a diagnostic tool. It's reported to miss between 50 to 70% of achalasia cases. The barium esophagram is a good tool. You can see the disease if it has progressed so much so that it's affected the anatomy. So you can see a typical bird beak appearance where there is spasm at the lower end and the column of liquid is having a bit of trouble getting through, and the dilated esophagus. However, it does have a low specificity, so it will miss early stage achalasia. The European guidelines advocate for CT scanning in patients that you think might have pseudoachalasia. So generally that's patients who are older, over 55, if they have a short onset of disease, less than 12 months, more than 10 kilograms of weight loss, or if the scope report has reported significant difficulty getting through the sphincter. So if patients have 2 or more of those, we would recommend a CT scan for those patients.
Very wise indeed in the guidelines. You mentioned several times, of course, the cardinal feature being the esophageal sphincter not relaxing. So when we need to pass the high-resolution manometry catheter, if it doesn't cross the esophageal sphincter, how could we then produce a quality study?
Well, that does happen with relative frequency. You can always get the information about the esophageal body, and I know that some centres will try little tricks like putting it into ice baths and so forth. But quite early in my career, we developed a tool with one of our interventional radiologists where we pass a thin guide wire through the stomach into the stomach first. That's been developed over time. We exchange it for a stiffer Terumo wire, and because we have a water perfuse system, we can then slide the manometry catheter through the central lumen. You wouldn't be able to do that if you had a solid state system. More recently, we have been using the endoscopic method to be able to pull it through or pass it alongside the scope once the scope has opened up the lower esophageal sphincter for us. That works very well. We just need to keep in mind that the patient might have been given a sedative or other types of drugs, so we need to let them recover. We tend to do their test and recovery, which just makes it a bit simpler for the patient.
So we're now confirmed the diagnosis of achalasia. What treatment options are available to patients?
There's 3 main treatments that's advocated in the literature that have long-term durability. Medicines aren't really recommended in the guidelines. They don't really have good effect. The 3 mainstay treatments that we would offer our patients and discuss in the outpatient clinic would be pneumatic dilatation, laparoscopic hilar myotomy, and the newest modality is the POIM procedure, so per-oral endoscopic myotomy. So at the outpatient clinic, we discuss all the pros and cons with the patients and let them decide based on what they think is best for them. I should point out, pneumatic dilatation isn't the dilatation that's carried out in endoscopy in the traditional sense. It's a type of dilatation carried out by the interventional radiologist where they feed a dedicated achalasia balloon across the geojunction under fluoroscopy and aim to rupture the muscle and diminish the pressure in the LOS. All of these treatments are going to give patients reflux, and we do counsel them about that, and it's quite easily treated by PPI usually. Patients do need to be under general anaesthetic for that, and we counsel them that generally for the pneumatic dilatation we won't achieve the optimal dilatation in the first sitting. With the first one we aim to get to about 30 millimetres of mercury, and then the subsequent up to 35 to 40 millimetres of mercury. That's not acceptable to some patients, and that can be a reason why they don't want that one. The laparoscopic hilar myotomy is a surgical procedure undertaken by general surgeons, and they make an incision in the lower esophageal sphincter through into the cardia. That has the advantage that we can also carry out a fundoplication, which mitigates the risk of reflux. In Scotland, we don't have a centre that carries out POEM procedures, but we do have a national agreement. We can send those patients to NHS England, which we have done, and that's patients' choice if they want to go forward with that.
Do patients have available resources they can access beside the consultation we have in clinic if they want to make an informed decision what is going to be the best option?
Yes, generally we would signpost patients to 2 charity websites. There's Action, Achalasia and Guts UK. So it allows the patient time to reflect, discuss their options with their family, and then get back in touch with us with what suits them most. One thing I should mention is that for the patients who sort of reach the end of the road, the only other treatment after that might be an esophagectomy. But that's for patients who are at end-stage disease, very tortuous esophagus. And because it's a complicated surgery, carries a mortality risk as well.
Is there a role for Botox in treatment of achalasia?
Botox has been used historically quite a bit. The guidelines now advocate it's only used for a bridge therapy perhaps. The Botox will wear off after about 6 to 9 months, so it requires repeated endoscopy and administration of that Botox. We also use it if a patient's unfit for general anaesthetic. We might advise it in that case. And also if a patient refuses to undergo any of the other modalities, we would consider Botox on a case-by-case basis.
So the patient undergoes treatment by their choice. They have relief of symptoms for several years, but then symptoms start to recur. Do patients have further treatment option at that stage?
Yes, they do, and we would expect that unless a patient's presenting quite late on in life, they're going to need multiple procedures. The procedures, if durable, they do last a number of years, but won't last forever. There's no real guidance on what path they should follow. They can move between therapies. Again, it's a matter of what suits them, taking into account any comorbidities that might have developed over time. How we reinvestigate them really depends on when they present in their journey, how long it's been since a treatment, for example, because we need to keep in mind patient could be presenting with dysphagia for another reason. It might be that they have developed cancer instead. So we know that the absolute risk of cancer for achalasic patients is low, but the relative risk is higher, especially if they have problems post-procedure with reflux disease.
And so if the patients have the possibility to undergo another procedure following the original one when the symptoms recur, how do we make this decision? Some of these cases can be particularly complex.
That's right. We do have a specialist achalasia clinic, so we would discuss with the patients and try and glean from them what's important to them, what's the main symptom that's troublesome, and also whether right away they might rule out one of the procedures. And so once we know that, we would discuss it at our upper benign MDT. It's a really valuable resource that we have where we discuss cases between medics, our consultant surgeons, and also the physiology department and radiology. So from that, we can get an understanding, looking at their comorbidities, perhaps how their procedure went first time or second time round, what might be the best option for them. Then we can rediscuss it with the patient.
Often patients have a very troublesome journey to get to the diagnosis of achalasia, a little bit because of the poor understanding around the conditions or the knowledge around it. How do we overcome this?
Yes, that's right. It's a very difficult one, and I think it's because we don't know a lot about it. There's a lot of theories as to what the barriers might be. The symptoms of achalasia are unspecific, so we think it's theorised that patients are maybe being treated for reflux disease, for example, for a number of years, which we have had patients that tell us that. We also don't know how many patients are perhaps reassured by their endoscopies being negative, and we don't know why they're maybe not going back or what the factors are in them seeking help, again, from their healthcare provider. I think a lot more research is needed to understand that in more detail and to map out the pathway for our service and our trust. I'm aware of one mapping exercise that was carried out for London, which did give some detail, but our population's very different. We've a lot of patients that live in the countryside. Access to services might be quite different for them. There's also a lack of guidance around this, especially in terms of follow-up. So a lot of patients do fall through the net there. We're quite fortunate that in our clinic we've committed to following patients up for the rest of their life basically, and they also know that they can contact us if in the interim they do develop some problems. Again, by mapping the pathway, I think we'll understand that a lot better, and we'll understand from research what the patient actually needs, and we can hopefully develop some guidelines from that. We've worked with Guts UK and Achalasia to try and develop a UK registry to address this problem. So I'm pleased to say that Guts UK have agreed to fund that, and we're hopeful that we can get this registry up and running and facilitate research that will lead to some guidelines in the future.
So you're very passionate about the achalasia topic, and I'm very fortunate working with you here, and I can say our patients with achalasia get gold standard treatment. So what would be your take-home messages for other gastroenterologists, trainee or general practitioners that are watching this episode of Digest This?
I think it's always to have pseudoachalasia in the back of the mind, so taking a really good detailed history just to make sure that's not an issue. The other thing I would say for centres that don't have a specialist clinic, setting that up or at least having a dedicated person will really help to standardise care. But also having the expertise of an MDT is hugely helpful, and it benefits the patient because at the end of the day they're getting advice from a consensus opinion.
Well, all that's left for me to say is to thank you for an excellent run through a very niche but topical issue in gastroenterology, and to thank you for joining us for Digest This.